The laryngeal tube is a new device for airway management, developed to secure the airway and to provide ventilation in patients undergoing surgery. It consists of a short S-shaped airway tube with a large cuff in the middle part of the tube. The proximal cuff provides a seal by forming a plug in the upper pharynx. The distal cuff is smaller and seals the esophageal inlet. The ventilation outlet is situated between the two cuffs. The two low-pressure cuffs are inflated by one inflation line, through which the cuff pressure can be monitored. The tip of the tube is soft and non-traumatic. The ventilation outlet of the laryngeal tube is placed in front of the vocal cords, as can be seen on the MRI picture. 6 color-coded sizes are available. Size 0 for infants less 5 kilograms, size 1 for babies between 5 and 12 kilograms, size 2 for children between 12 and 25 kilograms, size 3 for teenager and small adults less than 155 centimeters, size 4 for adults between 155 centimeters and 180 centimeters, size 5 for adults taller than 180 centimeters. The laryngeal tube is made of silicone and can be sterilized 50 times. After use, the laryngeal tube is soaked in a cleaning product for 15 minutes, then rinsed. The two cuffs must be completely deflated. The laryngeal tube is dried inside and outside by blowing and pre-packed and sterilized in an autoclave at 134 degrees centigrade. Clinical utilization. Before insertion, both cuffs are completely deflated and previously lubricated with either sterile water or with water gel such as Johnson's KY. After pre-oxygenation, anesthesia is induced with intravenous anesthesia, most often 2 to 3 milligrams per kilogram of propofol, associated or not with narcotics, and muscle relaxant are used. Alternatively, induction can be performed both in children and in adults, with sevoflurane 8% for 3 to 4 minutes. The laryngeal tube can be inserted after loss of the eyelash reflex and sufficient muscle relaxation. The patient's head is either maintained in a neutral position or in extension. Jaw thrust can be useful. The mouth is opened with the left hand and the laryngeal tube inserted in the center of the mouth until the black marks on the tube are level with the upper teeth. Both cuffs are now inflated with only one inflation line. Cuff inflation can be either made with a color-coded syringe or with a cuff pressure gauge. The pressure should be at approximately 60 centimeters H2O, which should be monitored continuously during the whole procedure with a cuff pressure gauge. The laryngeal tube is then connected to the ventilatory circuit. Appropriate placement is confirmed by the presence of end-tidal CO2 waveforms and a peak inspiratory pressure lower than 25 centimeters of water, and by easy efficient back ventilation without audible leak. In case of failure, the position of the laryngeal tube is adjusted by gently pushing or pulling the device. In children, extension of the head can improve ventilation and decrease the inspiratory pressure. After insertion of the bite block, the laryngeal tube is then firmly fixed to the face and the patient is either ventilated or breathes spontaneously. Positive pressure ventilation or pressure-controlled ventilation can be used. It is recommended to measure the air leak pressure and set the inspiratory pressure lower than the air leak pressure. Anesthesia is maintained deep enough to prevent vocal cord closure reflex. At the end of the procedure, the laryngeal tube is removed after complete cuff deflation, when the patient breathes spontaneously and has recovered airway protection reflexes. In adults, the laryngeal tube can be removed when the patient is completely awake. Results: in a study carried out in 70 children, insertion was successful in 88% of cases. Success rate increased with experience. Children were ventilated and inspiratory pressures were lower than 18 cm H2O. The average anesthesia time was 40 minutes. Recovery was quiet and no laryngospasm or desaturation episodes occurred. Sore throats were mild and infrequent. In adults, the success rate is higher than 95% and the morbidity is low. The laryngeal tube can be recommended for procedures under 2 hours long, either with spontaneous ventilation or with positive pressure ventilation, except in patients with a full stomach.